Coping with Bipolar Disorder, Part 2, Treatment of Mania and Depression. Much of the presentation on these slides is derived from my book, Calming the Bipolar Storm, a guide for patients and their families. Many of these topics are covered in greater depth in the book, also with extensive references. And the book is available on Amazon.com or from the publisher Rowman and Littlefield. That's Rowman with a W, R-O-W-M-A-N. Or you can order it through your favorite bookseller. A variety of different health professionals might be involved in treating someone with bipolar disorder. Psychiatrists are medical doctors who have MD or DO degrees and then have another 4 years of study specifically in psychiatry, diagnosing and treating mental and emotional disorders. Psychologists may have master's degrees 1 or 2 years after college graduation, or a PhD, which usually requires 4 or more years after obtaining a bachelor's degree. And they're very skilled in diagnosis, psychological testing, and various forms of individual and group psychotherapy or counseling. Social workers, some may have a bachelor's degree, others may have master's degrees in social work, and they're often very skilled at group and individual psychotherapy, marital psychotherapy, and looking at a patient's overall social situation. There may be other types of counselors there. For example, sometimes substance abuse counselors might be involved with a person with bipolar disorder. Primary care physicians, such as family practice, often get involved in managing medications of someone with bipolar disorder. Many family practice doctors have extra training in psychiatry. Sometimes internal medicine or pediatricians may be involved in treatment. And nowadays there's more nurse practitioners who often have specialization in psychiatry, often an extra year of training and a year of internship studying under a psychiatrist. And physician assistants also may specialize in psychiatry. Finding providers that you can feel comfortable with and who are competent is very important. Just having a good relationship or rapport with a provider in itself can be a very healing experience, and some studies even find that good rapport with a provider, be it a psychiatrist prescribing medications or a psychologist doing psychotherapy, may have more to do with the patient's improvement than the specific type of medications or the specific form of psychotherapy. Next, we turn to some of the specifics of medication treatments in mania and hypomania. Often if a patient is manic, they may wind up initially being treated in the hospital, although sometimes they can be treated as an outpatient. And folks that have hypomania are generally treated as an outpatient. And treatment often may take the form of a mood stabilizer, such as lithium, valproate, carbamazepine, or oxcarbazepine, or a second-generation antipsychotic, such as Abilify or Risperdal or some of the others that are listed here. Treatment with the mood stabilizers often takes 4 or 5 days just to get to a steady state, and then another week or few weeks to really have a good impact on reducing the manic symptoms. The second generation antipsychotics often begin working within hours to reduce agitation, and over a period of several more days often will cut down symptoms like hearing voices and delusional thinking. And it's not at all unusual for folks to be treated with both of these type of medications. In fact, we find people will have a generally shorter hospital stay when they're treated with one from each of these categories. But there is somewhat of a greater possibility of side effects when you have 2 medications rather than one. Australian psychiatrist John Cade used lithium to treat 10 hospitalized patients and published a paper back around 1949. This really was the beginning of the modern era of psychopharmacology. Prior to that, medications were known to be able to sedate someone who was agitated, make them a bit sleepy, but the concept that they might have fairly specific therapeutic effects for disorders like mania or depression or schizophrenia or panic attacks was kind of foreign to our thinking in the beginning of the 20th century. But after lithium's introduction, other medications showed that they could have rather specific effects. All 10 of the patients he treated with lithium got better. One was a person who had been in the hospital continuously for 5 years who was able to go home. But the medications do have side effects, such as tremor or problems with upset stomach or diarrhea, weight gain, sedation, hypothyroidism, increased urination. And it was soon discovered that it was quite crucial to be able to get blood levels of lithium so that you didn't have toxic side effects, but you had enough to perform a therapeutic effect. And the same is generally true with valproate or Depakote, which also can have tremor and gastrointestinal side effects, weight gain, and sedation, and where we also get blood levels to be sure it's not at a toxic level or so low that it's not going to be helpful. Now, what do we actually mean by the term mood stabilizer? Well, actually, its meaning is a little bit vague, but we can usually say it means that a drug helps in at least one of the 3 phases of bipolar treatment, mania, depression, or the maintenance phase, and it doesn't make the patient worse in any of those phases. So drugs like lithium and Depakote have a good track record of helping both mania and depression, and also in the maintenance phase of reducing relapse. And to a lesser extent, I would say carbamazepine and oxcarbazepine also do. Carbamazepine is FDA approved for treating mania, whereas oxcarbazepine is not in the United States. It is in some other countries. They both will generally help with manic symptoms, and they're often used for maintenance as well. and they may even sometimes help the depressed phase. But they can have side effects, such as they both can have some severe skin rashes or elevated liver enzymes. Carbamazepine especially can affect the metabolism of other drugs, such as, birth control pills would be one, where sometimes adding carbamazepine might reduce the level of the birth control pill to such an extent that it no longer is preventing birth. So often drugs might have to be adjusted when using that particular medication. Sometimes they might cause some sleepiness, mental dulling, or a low sodium. And oftentimes we have to do some checks on the red and white cells in the blood and the platelets, and checking liver enzymes. Now we'll talk about the antipsychotic drugs, so-called because they reduce psychotic symptoms such as hallucinations and delusions, often within a matter of days, sometimes even within hours of starting treatment. And they reduce agitation, usually within a matter of a few hours of treatment. The first generation antipsychotics were drugs such as thorazine, or its generic name chlorpromazine, and a dozen or so others followed that, including familiar names like Haldol or haloperidol. But the second generation antipsychotics, or sometimes called atypical antipsychotics, because they didn't seem to have the neurologic kinds of side effects that the first generation antipsychotics did. And that's why we generally use them much more nowadays than the first generation antipsychotics, because they do have fewer of these neurologic side effects that we'll talk about shortly. Well, let's talk about these neurologic side effects of antipsychotics. Acute dystonia means a disordered state of muscle tonicity or contraction. For example, sometimes after a patient might have received some haloperidol, he might have a contraction in his neck that makes his neck twist to one side like a severe wry neck. Or another form of dystonia is having one's eyes gaze upward in a fashion that you can't bring your gaze down. It's sort of a forced contraction. So these can be rather distressing and frightening for a person to undergo. We do have other medicines that can rapidly reverse these dystonias, but still they're certainly something that may make a person very anxious and not too eager to take such a medication again that would cause something like that. Pseudo-Parkinsonism usually comes along at least a number of days after starting an antipsychotic, sometimes not for weeks or months. And it just means that it simulates Parkinson's disease, in the sense we often have a fixed regular tremor. Sometimes there's a rigidity in the muscles, a flattening of expression in the face, a reduced blink rate. Often the person has balance problems, difficulty walking and getting up from a chair. Many of the typical symptoms we see in Parkinsonism can occur. Akathisia means is experienced as a great deal of internal restlessness. We observe a patient with jiggling their legs or wanting to get up and pace. Tardive dyskinesia means tardive means it doesn't show up for many weeks or a number of months after the medication is started, but we still have a dyskinesia or abnormal movement. Often there's movement of the face, such as blinking, grimacing, extending the tongue. Sometimes there's wiggly movements of the fingers or choreiform, dance-like or athetoid, worm-like movements in other parts of the body. And neuroleptic malignant syndrome is another disorder that's characterized by often high blood pressure and temperature and rigid muscles. It's really a medical emergency, and it might happen to maybe as many as 1% of patients hospitalized for a psychotic disorder and treated with antipsychotics. There have been various studies done to document the frequency of tardive dyskinesia. With the older first-generation antipsychotics like Haldol and Thorazine, researchers were seeing 5 to 8% of persons who were on those medicines continuously for a year developing tardive dyskinesia. With the second-generation antipsychotics, the rates were much lower, more in the neighborhood of 0.8 to 2.9% per year. What are some of the risk factors for developing tardive dyskinesia? Well, older age is one. Older people tend to develop it more rapidly than younger people, or more easily. Female sex more so than male. Persons of African American background may have a higher incidence of tardive dyskinesia. Non-schizophrenic patients, they're certainly bipolar patients, may make use of these second-generation antipsychotics, both in the manic phase and the depressed phase. Or persons with psychotic depression or refractory unipolar depression are sometimes treated with second-generation antipsychotics. Diabetes mellitus is a risk factor. If a patient is also on lithium or an anti-Parkinson drug at the time, that appears to be a risk factor. And if movement problems develop early in treatment, that is, persons who might early on develop a dystonia or the Pseudo-Parkinson syndrome or akathisia, they seem to be more susceptible to developing tardive dyskinesia. We'll move on from our discussion of the neurologic side effects of the second-generation antipsychotics to other types of side effects. And the problems of weight gain are a significant one. This also tends to differ according to the particular medication used. Clozapine and olanzapine seem to be the worst offenders for weight gain. Perhaps clozapine edging out olanzapine as the worst. Catiopene and risperidone are intermediate. That would be Seroquel and Risperdal as their brand names. And ziprasidone or Geodon and aripiprazole or Abilify seem to be the least likely to add weight gain. Some of the newest of the second-generation antipsychotics don't have quite as many studies documenting where they fit in risk for weight gain, but we can say that they are less than olanzapine or Zyprexa. That is the lurasidone or Latuda, the asenapine or Safras is the brand name, iloperidone, which is Fanapt, the cariprazine, which is Vraylar, and brexpiprazole, which is Rexulti. They all have at least less tendency for weight gain than olanzapine. And we're concerned about the weight gain not simply because you don't like the way you look with an extra 10 pounds or you're not fitting into your clothes anymore, but because it can bring on other health problems. Along with obesity can come high blood pressure or hypertension. Diabetes mellitus type 2 is strongly correlated with obesity, as is hyperlipidemia, which is an elevation of certain fats in the blood, cholesterol or triglycerides. And of course, those disorders put one at greater risk for cardiovascular disease and ultimately heart attack and stroke. So if someone gains weight in 2 weeks on one of these drugs, that's a prediction that they're going to keep gaining more weight in the long run. Another possible side effect of the second-generation antipsychotics is prolactin elevation. Prolactin is a hormone that's normally secreted by the pituitary gland at the base of our brain, and it's secreted when mothers give birth and are nursing. It tends to enlarge breast tissue and cause milk to form and be secreted. And when it happens as a side effect from certain drugs, it also can have that effect of causing some enlargement of breast tissue in both men and women, and some milky discharge from the breasts, again in both men and women. So this can be a distressing and alarming, unpleasant side effect from some second-generation antipsychotics. I've only seen it myself, really, in risperidone and paliperidone, and these seem to be by far the worst offenders. If it does occur in the other second-generation antipsychotics, it's very rare. And it occurs in first-generation antipsychotics, such as Haldol and Stelazine. And when we discover this, the drug is usually stopped, and the milky discharge goes away as the prolactin levels drop. The only other, or one other potential problem if prolactin levels are increased for a long time, could be some osteoporosis or thinning of the bones. Another possible side effect of some second-generation antipsychotics would be an elevation of prolactin levels. Prolactin is a hormone secreted by the pituitary gland, and its normal role occurs when a woman gives birth and is nursing. A prolactin increase in her bloodstream causes an increase in breast tissue and causes milk to be produced and secreted. When prolactin levels get increased as a side effect of drugs, it has the same effect. Namely, it can increase breast tissue and lead to a milky discharge from the breasts, and this can occur in both men and women. Other effects from increased prolactin levels could include the abnormal menstrual patterns or cessation of menstruation, and also could cause impotence in some men. And one other theoretical problem, if prolactin levels are elevated for a long time, could be thinning of the bones or osteoporosis. I've only really seen increased prolactin levels in risperidone and paliperidone among the second-generation antipsychotics. If it occurs in the others, it is indeed rare. And it does occur in first-generation antipsychotics, such as haloperidol or stelazine. Usually if this problem occurs from the drug is stopped and the prolactin levels gradually subside and the problem with milky discharge or impotence or whatever goes away. Other assorted side effects from second-generation antipsychotics could include hypotension, or what we call orthostatic hypotension, where blood pressure drops significantly from a sitting to a standing position. So sometimes folks might get dizzy when they stand up and have to do that carefully, or in a real severe case, they might have some episodes of passing out and have to stop the medication completely. Many of the second-generation antipsychotics can cause sleepiness. Probably Catiopene or Seroquel is well known for that. Olanzapine's up there. Others like the ziprasidone and aripiprazole are lower on the sleepiness scale. Seizures is also unusual but documented possible side effect from some of these medications. Impairment in swallowing occasionally occurs. Impairment in temperature regulation. This usually would take the form of someone in the summertime developing a febrile temperature because their temperature regulating mechanisms such as sweating are not acting as they should. Increased suicidality has been added by the FDA as a group warning for antidepressants, because several of the second generation antipsychotics like Catiopene, aripiprazole, olanzapine have been used as adjuncts to antidepressants, and that class warning comes along with that. Anticholinergic side effects occur in many of these medications, and they occur in many non-psychiatric medications that are used in general practice, drugs used for gastrointestinal disorders, for drugs used in ophthalmology, cardiology. And there's a cluster of possible side effects when anticholinergic effects occur. This means that the drug is blocking the acetylcholine neurotransmitter. Some of these side effects would include dry mouth, constipation, difficulty urinating, blurred vision, increased heart rate, and especially in the elderly, possible confusion. Besides the mood stabilizers like lithium and valproate and the antipsychotic drugs, which we've just been talking about, what other drugs are sometimes used in the manic phase? Well, the benzodiazepines such as lorazepam, Ativan, or diazepam, Valium are sometimes used simply to reduce agitation and anxiety levels. Similarly, the Z drugs such as zolpidem or Ambien and several of the others in that category may be used to aid sleep, which is often sorely needed in a manic phase for a person with bipolar disorder. Calcium channel blockers might be rarely used to treat mania. A few studies that support that. Allopurinol, which is a drug that reduces the uric acid levels in the blood, has a number of documented studies showing that it reduces manic symptoms as well. And I had one patient of my own that I wound up using allopurinol to help reduce mania and as a maintenance medication as well. And ECT, or electroconvulsive therapy, best known for treating severe depression, also can be effective against mania when other things aren't working, or perhaps you have a manic lady who's pregnant, and the decision might be made to try ECT rather than using a lot of other medications that would also be exposed to the fetus. Now we'll turn from our discussion of the treatment of mania to our discussion of the treatment of bipolar depression. As we can see from our slide, folks with bipolar disorder tend to spend a lot more time in the depressed mode than they do in the manic or hypomanic mode. 3 times more days spent depressed than manic for bipolar 1, and 39 times more days depressed than hypomanic for bipolar 2 patients. It's also the case that there's only 4 or 5 approved treatments for bipolar depression, FDA-approved treatments, whereas at least a dozen medications have been approved for treatment of acute mania. And the response to the treatments for bipolar depression are slower, whereas some of the drugs for acute mania will show improvement in hours or a day or two, significant improvement. Most of the drugs used to treat bipolar depression act rather slowly, so that you may not see much of improvement for a couple weeks, and you may not really see a full remission or recovery for 4 to 6 weeks from the start of treatment. Sometimes it happens faster, but many times it is a slow process like that. When a bipolar patient becomes depressed, it's certainly good to look for possible triggers for that depression. Did they start a blood pressure medication that has a potential for causing depression? If so, maybe that could be stopped and switched to an alternative. Has the person begun having an alcohol abuse problem, and that played a factor in their sinking into depression? If so, that might be a target for treatment. Has there been a loss of some relationship or job or other factor that brings on a component of grief with the depression, and is that something that could respond to some psychotherapy to process that loss? Is it a seasonal wintertime depression, in which case perhaps a bright light treatment might be a good ticket for recovery? If a person with bipolar disorder has suddenly become depressed and they're already on a mood stabilizer, is the dose sufficient? Some people will respond better if their lithium level is boosted above 0.8 or their Depakote or valproate level is boosted above 80 micrograms per ml. Research indicates that those mood stabilizers are more effective at those higher doses, although they do have a potential for more side effects. If they're already on lamotrigine, Lamictal, and tolerating it without any side effects, sometimes the dose of that could be increased, and that might be sufficient to improve a depressed mood. It's also important to look at what has helped in the past. If a certain combination of medications were successful in the past, there's a fairly good chance that they'll be successful again. Well, why not simply try an antidepressant like Prozac or one of the other SSRIs or other antidepressants? Well, in general, their track record has not been great for bipolar depression, not as good as the FDA-approved medications for bipolar depression. Although in individual cases, somebody that has a real good history of responding to a particular agent, that certainly is a consideration. The other drawback with the standard antidepressants is that there is a risk for them to cause a switch from depression into hypomania or mania. Much of that risk is reduced if they're also taking a mood stabilizer like lithium or Depakote or a second-generation antipsychotic. But there still is a little risk there. In the last 20 years, we've had 5 different agents FDA approved for the treatment of bipolar depression. These chemical agents have come from the family of second-generation antipsychotics. The first was a combination of olanzapine, which is Zyprexa, and fluoxetine, which is Prozac. And in the studies that got that combination approved, folks improved in their depression on either of those drugs alone, and then with the combination, they improved quite a bit more. Catiopene or Seroquel was approved in 2006, and it comes in immediate release or extended release forms. Lorazepam or Latuda was approved in 2013 for bipolar depression. Cariprazine or Vraylar was approved in 2019 for bipolar depression, and it's also approved for treatment of mania. And the newest comer on the block would be the Caplyta or lumateperone, which is approved to be used alone or with a mood stabilizer. Just approval coming within this past year or in 2021. In practice, I would say that all of these agents are at times used with mood stabilizers, and some, for example, Catiopene has FDA approval for its use with mood stabilizers in manic episodes and in maintenance of bipolar disorder, although it isn't specifically approved for use with those mood stabilizers, lithium and valproate, during the depression episodes. So the Symbyax or olanzapine fluoxetine combination unfortunately can draw side effects from both of these agents, so we see kind of a combination of additive side effects from the two drugs. You can have weight gain, you can have increased blood sugar and lipids such as cholesterol and triglyceride. And interestingly enough, some people will have higher blood sugars even without gaining weight. So that does have to be monitored. It can cause sleepiness, dry mouth, and probably more from the fluoxetine, sexual dysfunction such as delayed orgasm or anorgasmia. Catiopene side effects include the sleepiness fairly prominently, and it's often stated that most of the sleepiness occurs up to 200 milligrams, and it doesn't seem to increase as you go up with the dose beyond that. But and sometimes the sleepiness goes away, but there are certainly many folks that just can't tolerate the catiopene and have to try a different agent that causes less sleepiness. Also, it causes weight gain, less so than olanzapine, and increases in blood sugar and lipids, again less so than olanzapine. It's rather low on the neuromuscular side effects as far as the Pseudo-Parkinsonism or dystonias. So that's certainly a plus. And as discussed in the few slides back, it's FDA approved to be used alone or with mood stabilizers. The mood stabilizer adjunct is there for the mania and mixed episodes and for maintenance. So at least it's judged to be a safe combination, even though they didn't specifically get approval for using it in bipolar depression along with lithium and Depakote. And as far as side effects for Latuda or Lorazepam, it can cause some sleepiness, but less so than the Catiopene or olanzapine. It can cause some of the weight gain, but again, less so than those other two agents. It does tend to cause a few more of the neurologic kinds of side effects in some folks. The akathisia or extreme restlessness can sometimes occur, and pseudo-Parkinsonism, where someone taking the drug after a number of weeks or months starts to have muscle stiffness and tremor and poor balance, and they either have to stop the drug or can sometimes take in an anti-Parkinson agent with it. And it can cause occasional nausea and vomiting. And Latuda is supposed to be taken with a meal, at least 350 calories. So most people take it with their evening meal or the main meal of the day. It's much better absorbed when taken with food so that you really get the full benefit of the dose that way. Cariprazine, brand named Vraylar, is relatively low on the sleepiness side effect and low on the weight gain side effect. Does have some moderate akathisia effects causing the restlessness side effect. And the newest drug to join the group as FDA-approved treatments for bipolar depression is lumateperone, just recently approved in either very late 2021 or early 2022. Approved for the treatment of depression in both bipolar 1 and bipolar 2 patients. And it's also approved for treatment of schizophrenia. And it was very low in side effects, essentially no problems with weight gain or the metabolic syndromes such as high blood sugars or high blood lipids like cholesterol or triglycerides. Almost no neurologic effects, no incidences of akathisia or pseudo-Parkinsonism. There was some sleepiness in about 8% of patients, some nausea in 6%, but compared to many of the other antipsychotics, very low incidence of side effects. And the lumateperone is a bit different chemically. It targets several different receptors in the nervous system, and that may be related to its low side effect profile. We've talked about the second generation antipsychotics that are FDA approved for bipolar depression. And now we turn to some of the traditional antidepressants. First, the selective serotonin reuptake inhibitors like Prozac, Zoloft, Paxil, Luvox, Celexa, and Lexapro, and their generic names listed first and the brand name second here. And these usually are not the first choice for treating bipolar depression. However, if someone has a clear past history of a good response to these as antidepressants, that may be a reason to use it. Or sometimes if they've used these drugs in a maintenance phase and they become depressed when you take them off the drug, that may be another consideration for reinstating or using these. But overall, as a family, they seem to be a bit less effective than the second generation antipsychotics we mentioned earlier. And they all have some side effects in common, such as weight gain. They have sexual dysfunction, such as the inhibition of orgasm or delay of orgasm, and sometimes perhaps impotence. They can cause nausea, vomiting, and diarrhea. And sometimes they can cause suicidal thoughts, particularly in adolescents or young adults under age up to age 24. Usually we do not see that effect if you look at older individuals treated with these drugs. And the drugs themselves do each differ somewhat. Some may be more or less sedating, some have more or less of the weight gain and gastrointestinal side effects and so forth. And we also have the family of SNRIs, serotonin norepinephrine reuptake inhibitors, that includes venlafaxine or Effexor, duloxetine or Cymbalta, desvenlafaxine or Pristiq, and levomilnacipran or Fetsima. And they all have the side effects common to SSRIs from inhibiting serotonin reuptake, and they also might have other side effects from their effect on the norepinephrine system of increased heart rate or increased blood pressure. Usually that's not a dramatic thing, but sometimes might be 5 to 10 millimeters of mercury in some situations, which might be clinically worrisome if somebody's already has some high blood pressure readings. And then we have assorted other newer antidepressants. Bupropion or Wellbutrin is not so new. It acts primarily on the norepinephrine system and is very non-sedating and supposed to have no sexual side effects. Mirtazapine and trazodone both tend to be relatively sedating agents, and mirtazapine associated with weight gain many times. Nefazodone, kind of a cousin of trazodone, also usually given at bedtime because it's sedating. Not used much in the United States because there had been some incidents of serious liver toxicity with it. And then two relatively newcomers, vortioxetine or Trintellix, vilazodone or Vibrid, that are have some serotonin reuptake activities, plus effects on some of the other serotonin receptors. Another family of antidepressants occasionally used in bipolar depression would be the older tricyclic antidepressants. They're called tricyclic because their chemical structure includes three kind of conjoined rings. Imipramine was the first that came out, tofranil or imipramine, probably in the late 1950s. Others followed that in the 50s and 60s. The last one on the list there, clomipramine or anafranil, is FDA approved just for treatment of obsessive compulsive disorder. And although it is also a potent antidepressant. And these drugs may have a number of side effects in common. Sometimes dizziness upon standing is a bad side effect. What we call orthostatic hypotension, where your blood pressure drops from the sitting to the standing position, and people can get dizzy or even sometimes fall or pass out. And then some of the anticholinergic side effects: dry mouth, constipation, urinary retention. In elderly folks, sometimes confusion is another one of those anticholinergic effects, and the blurry vision as well. They do tend to cause some weight gain, have some potential for causing cardiac arrhythmias. They're much more dangerous in overdose than the SSRIs like Prozac, and that's another reason they're used much less. And they seem to have more propensity than the SSRIs for causing a switch from depression right into mania, or to causing the rapid cycling pattern, which we always want to avoid. Another family of antidepressants that's used rarely in bipolar depression would be the Mao inhibitor antidepressants. It's interesting that these were actually the first antidepressants discovered back around the middle of the 20th century. Back in the early 20th century, the whole concept of an antidepressant was not heard of, or not necessarily imagined that a drug could actually reverse depression. But there was a drug used for patients with tuberculosis, iproniazid, which happened to be an MAO inhibitor. And lo and behold, many of the patients treated for their tuberculosis, who were quite depressed as well, suddenly found their depression lifting. And this led to the discovery of the MAO inhibitors as a class of antidepressants. They're used rarely now because they do have a lot of side effects. They have some of the dizziness or orthostatic hypotension side effects that the tricyclics have, such as getting dizzy when you stand up from a sitting or lying position. And they have some of the dry mouth, blurry vision kinds of side effects, but probably less so than the tricyclics did. Sometimes they may be a bit overstimulating, or some can be a bit sedating at times. And they have a potential for very negative interaction with certain foods and drugs. What is called the cheese reaction is when people ingested aged cheeses or some aged meats that contain the amino acid tyramine. The tyramine, when affected by the MAO inhibitors, led to a false neurotransmitter being spread in the synapse and causing a hypertensive crisis in some patients where their blood pressure shot up because this false neurotransmitter mimicked the effects of norepinephrine, which is our natural physiologic agent that the body uses to raise our blood pressure when we need to. And so there's a number of foodstuffs that are to be avoided when you use MAO inhibitors, and a number of drugs. One common example would be Sudafed or pseudoephedrine that could also cause this cheese reaction or false neurotransmitter that might cause severe high blood pressure. Other drugs used in bipolar depression, this is primarily when first and second line treatments haven't succeeded. Sometimes a stimulant drug might be added, such as Ritalin or an amphetamine or one of the wakefulness-inducing drugs that's used to treat narcolepsy. Pramipexole is used as a dopamine stimulator that's used in Parkinson's disease and restless legs syndrome. Nimodipine is a calcium channel blocker. Sometimes thyroid in the form of T3 or T4 might be added, and there's and all of these do have some studies confirming that they're sometimes beneficial and can be used safely. Vitamin D3 sometimes might be added, primarily if someone is a borderline or low vitamin D level. And then we have a couple of nutritional agents, omega-3 fatty acids. There's fairly good evidence from quite a few studies that omega-3 fatty acids might improve overall mood stability and aid someone emerging from a bipolar depression. And similarly, the case for N-acetylcysteine, another nutritional agent that can be purchased in health food stores. One of the drawbacks of all these antidepressant type treatments for bipolar depression is that they take a while to work. Frequently, you don't see any response for a few weeks and may not really get a peak response for 4 to 6 weeks with a particular dose. The use of ketamine for acute treatment of depression promises to change that. It's still an experimental treatment. It hasn't been FDA approved for treating unipolar or bipolar depression, but there have been quite a few studies documenting its use for this purpose. Usually it's given in an IV route, and the antidepressant effects seem to occur rapidly as soon as 40 minutes and peak in about 1 day. And the response may last for 3 days to 12 days. So you might have to give repeat injections of it. But it's been found to, as I say, rather rapidly reverse symptoms of depression, and in particular, suicidality is often something that can be reversed with the ketamine protocols. Side effect wise, of course, ketamine has been used for quite a while as an anesthetic. The doses used for the antidepressant treatment are quite a bit lower than the anesthetic doses. But still, sometimes people get a dissociative, out-of-body sort of feeling from it, which may not be a pleasant thing at all. Many times they might get an increase in heart rate and blood pressure, and so that has to be monitored. And ketamine is a drug that can be prone to abuse. It can be in a oral or IM form or inhaled. So we have that concern that people who are highly prone to drug abuse might be triggered into doing something like that. But it is a potential paradigm shift in the treatment of depression because it works so rapidly and presumably by a different mechanism molecularly through the NMDA receptors. And as a spin-off from ketamine is a chemically related drug, S-ketamine, which is delivered as a nasal spray. And it's is FDA approved for the treatment of depression, but only under very limited circumstances through certain centers that are licensed and certified to use this S-ketamine treatment, used along with an antidepressant. And it also may have rapid improvement of depression with its usage. And this is very likely something which we'll be hearing more about in the near future as a treatment for unipolar and bipolar depression. We'll discuss some other possible treatments for bipolar depression. Sleep deprivation, of course, we know that is a factor that can trigger mania in bipolar persons. But sometimes it can be used therapeutically. In that case, we might have someone awakened at 3 a.m. and have them stay up. And many times within that very day, their mood lifts. They're not nearly as depressed. Sometimes that improvement is lasting. Sometimes when they go to sleep the next night and wake up the following morning, they're depressed again. But I have used that technique with some patients myself, and sometimes been able to help them rapidly get out of a bipolar depression. Bright light treatment has been around for a while for the treatment of what's called SAD, seasonal affective disorder. And some folks with seasonal affective disorder have bipolar disorder, where they get depressed and lethargic in the winters, and then in the summertime they may have periods of hypomania where they feel lots of energy and are very happy and productive. And it's believed that the light cycle, when we're exposed to much more light in the summertime and less in the winter, that this has a effect on our moods, perhaps through the melatonin system, which is one of the systems related to our sleep and wakefulness. But the treatment itself, nowadays, the most common form would be to use a bright light of 10,000 lux, that's a measurement of brightness, to have a patient sit 18 inches away from the light, not staring into the light because it's very bright, but just sort of occasionally glancing up at the light or reading with the light shining down on a book for about 30 minutes in the morning. And that often can help people, certainly with the seasonal mood disorders, but it also helps some people with unipolar or bipolar depression who don't have a seasonal pattern. And it doesn't usually work as rapidly as ketamine, but sometimes we'll see improvements over a week or 2 weeks with this kind of a treatment. The final category of treatments that we'll discuss for bipolar depression is neuromodulation. This includes repetitive transcranial magnetic stimulation, which has been around for a while, used for the treatment of unipolar depression, but also hundreds of, if not more, patients with bipolar depression have used that modality of treatment, and studies indicate that it is effective for bipolar depression. Nothing that outstrips the 5 drugs that we know are FDA approved for the treatment of bipolar depression. That is, the rates of improvement aren't anything that greatly surpasses that by any means, but they're more on the order of that. And it's usually patients get the treatment as an outpatient for about 5 days a week, lasting for about 6 weeks or so. The treatment itself lasts about 30 minutes. They have electrodes placed on one side of their scalp, usually over the dorsal prefrontal cortex, and a rapidly alternating magnetic field is created there in the first few centimeters of brain tissue below the skull. This actually has an effect of an electrical stimulation on the nerve cells. And one advantage is that there's very few side effects from this. Some people might get a headache or some irritation at the site of the electrodes, but you don't have the kinds of side effects you do with the drug treatments. And I think it's also a slow onset of improvement, much as we see with our standard drug treatments over a period of weeks. Transcranial direct current stimulation is a newcomer and doesn't have as much of a track record as the transcranial magnetic stimulation, but it also has promising results in some of the early studies. And it's, again, 2 electrodes placed on one side of the scalp with a direct current pass through them, causing, again, electrical stimulation of the underlying brain tissue. One advantage of the TDCS, the direct current stimulation, is that the equipment is much less expensive and far more portable than the equipment for transcranial magnetic stimulation, which is, very, very heavy, not easily transported, and rather expensive. And certainly researchers are dealing with manipulating, the levels of electricity and the duration of treatments to try to get a more optimal response from these modalities. ECT, electroconvulsive therapy, has been around since at least 1932, when an Italian psychiatrist, Ugo Cerletti, first used it. And it really is the most effective treatment for severe depression, both in certainly unipolar severe depression and very effective for severe bipolar depression. It's often reserved for those who haven't responded to medications, or if someone is severely psychotic or suicidal, or someone who's not taking any food or nutrition. Sometimes it can be a life-saving procedure. And sometimes it's used for a pregnant woman who has severe depression, because you don't have to expose the fetus to large amounts of medications, which you would if you were treated with second-generation antipsychotics or with lithium or one of the other mood stabilizers. And you see a fairly rapid response. About 30% of folks respond in about a week, and about 75% in 3 weeks with ECT. Some of the side effects can include people having a retrograde amnesia, not remembering what happened right at the time they were given the treatments and a little bit before that. Also, for a few weeks after the treatments, their memory for learning new things may not be as good. But if you look at their memories out there a number of weeks or months and compare those to other similar patients who've had severe depression but haven't had ECT, you don't really see cognitive deficits from the ECT in terms of deficits in memory or creativity or executive function. So it's a treatment that is still around and very effective, but often used for treatment, folks who've been treatment refractory, not responding to other medications. Vagus nerve stimulation was kind of discovered when they were using vagal nerve stimulation to reduce seizures in folks with epilepsy, and they saw a number of them showing improvement in their mood. So it has been FDA approved for the treatment of depression, both unipolar and bipolar. And it involves the placement of a stimulator under the skin that stimulates the vagus nerve in the neck. That vagus nerve has further connections up into the brain stem and on up into the limbic system of the amygdala and hippocampus and on up into the frontal cortex. So it was mostly tested with folks that had severe and refractory depressions and was shown to lead to definite improvements, at least in a number of them. Again, the numbers that improved were not overwhelmingly great, but it was a very severely ill group of patients that it was tested on. So we see we have lots of different possibilities for the treatment of bipolar mania and bipolar depression. And in some future programs, we'll get more into psychotherapy treatments, which are sometimes used for bipolar depression and also in a period of bipolar maintenance to try to help prevent relapses.